Welcome to Bullet Point Nursing. My name is Dr. Goldstein, and in this lecture series, we're going to go through essentially everything you need to know for nursing pharmacology. Whether you're here as a nurse practitioner student, a nursing student, or just here to refresh for the NCLEX or for your practice, let's go ahead and continue on with our next lecture. Today, we're going to be talking about reproductive health, and in here, we're going to cover men's health, women's health, and a little bit about STDs. So to begin with, we're going to talk about oral contraceptive, among the most commonly used medications today in the United States. So the drug class is going to be oral contraceptive, or OCP. You may also see referred to, especially in newer textbooks, as COC, or combined oral contraceptive. In either case, what drugs are we talking about? We're talking about a drug that is given for contraception, and it includes an estrogen and a progesterone component. Anything that includes both of those is what we're talking about when we say a combined oral contraceptive, or COC or OCP. There are some exceptions, and there are some different ingredients that different one of these medications use, but generally speaking, the most common ingredients are going to be norethindrone and ethinyl estradiol, with norethindrone being the progesterone and ethinyl estradiol being the estrogen. The mechanism of action is that these suppress ovulation by suppressing luteinizing hormone. It does get a little bit more complex than that, but at the RN level, we're going to leave it at that. For NP students, you may need to know a little bit more that we're actually not going to get into. So what do we use this for? This medication is used for contraception. It's also used for acne. We do use it a lot for some off-label uses, including PCOS, menstrual suppression, and dysmenorrhea, which is irregular periods. This medication and pretty much all medications that contain estrogen have a black box warning for an increased risk of thromboembolic events, aka blood clots. In this case, it specifically says increased risk of thromboembolic events when combined with smoking. Now, oral contraceptive pills are available in 24 or 28-day cycles. By far, the most common is a 28-day cycle. In a 91-day cycle, which is where they take the active pill for 84 days and then 7 days of placebo. And then finally, a 365-day cycle so that the patient doesn't ever have that withdrawal bleeding, what we call a period. The 28-day cycle, which is the most common, is the one we'll discuss a little bit further. It comes as 21 tablets of active medication, and then it has 7 tablets of either a placebo or iron. In either case, it is meant just to keep the patient on the same schedule of taking a pill every single morning, even when they're experiencing their withdrawal bleeding, which we call a period. Several medication classes, most notably anti-seizure medications and antibiotics, are known to reduce the efficacy of oral contraceptives. Unfortunately, please note that some of these medications are actually teratogenic. So not only would they decrease the efficacy of your birth control, but now that you did become pregnant, you need to get off of this because these medications are teratogenic. So that's definitely something that you need to keep in mind. What patient education do you need to provide? Well, as an RN, there's going to be a whole bunch of it. So let's start at the beginning. First of all, you should start taking this at least 5 days from the onset of your bleeding. Most commonly, it is taken on a Sunday. It doesn't have to be, but that is the recommendation. You should use an alternative method of contraception when you first begin taking this medication. And that's because it doesn't start to have its effect on day one. If a patient misses one pill, they should just take it whenever they remember and then continue on. If they completely forgot for the whole day, they should take 2 the next day and then continue forward. If a patient missed 2 days of doses, they should double up for the next 2 days, but they also need to use an alternative method of contraception for at least the next 7 days. If a patient misses 3 days of medication, they're likely to start to experience withdrawal bleeding. They should just plan to stop taking it for at least 7 full days, allow themselves to have their period, and then go ahead and continue starting a new path after at least 7 days. If a patient does become pregnant, they should, of course, immediately stop taking this medication because it is teratogenic. The next drug class we're going to look at is a subset of oral contraceptives, but it's not part of COC, or combined oral contraceptives. It's called POP, or progesterone-only pill. The medication here is norethindrone, and there are some other ingredients, and this is known as the mini pill. The mechanism of action actually has 4 different ways that it suppresses the likelihood of a patient becoming pregnant. One interesting thing to note When patients are on these medications, the estrogen component of the COC is meant to regulate their cycles versus the progesterone component is really more of what's meant to prevent contraception, to prevent conception, to prevent them from actually becoming pregnant. When a patient is taking their medication, they should be educated to ensure that they're taking it regularly without any issues, and that they should continue taking it as prescribed. The progesterone only has a big issue that it must be taken every single day at the same time in order to increase its effectiveness. It is generally considered less effective than a combination medication for contraception. I know we said that of the two ingredients, progesterone is the one more focused on contraception. However, the two together with estrogen do work better for preventing pregnancy. Progesterone only has a little bit lower efficacy for preventing pregnancy. Patients who are taking progesterone only do not stop during withdrawal bleeding. They continue taking their medication straight on through every single day without stopping. One big advantage to taking this medication is you can start taking it immediately after childbirth to prevent future pregnancies. Next, we're going to look at preventing contraception in the emergency, or preventing conception in the emergency setting. The drug class here is called emergency contraceptives. The drugs are levonorgestrel or ulipristal, very commonly known as Plan B, Plan B one-step, or ELA. The mechanism of action is that these interfere with ovulation. What do we use it for? We use it for emergency contraceptive, and it is only effective when used within the first 5 days of unprotected intercourse. However, also note that this medication should be taken as early as possible after unprotected intercourse. It is more effective the sooner it's taken as opposed to when it gets out to the full 5 days. Patients who have a high BMI, you should know what a normal BMI is. Patients who have a higher BMI have a significantly lower efficacy when using this medication. This medication does not induce an abortion. So this is not an abortion pill. However, of course, it should not be taken in pregnancy. This medication is also available over the counter, and it should, and it does not require a prescription. The abortion pill in the United States is a drug called mifepristone and misoprostol. It's a combination of two separate medications. One is a steroid and one is a prostaglandin, and the two together are what we call the abortion pill today. So moving on from preventing pregnancy to trying to become pregnant. First of all, let's talk about a few different notes related to becoming pregnant in terms of pharmacology. I want to preface all this by saying that this data changes day by day, and you should not take anything that's here and go ahead and act on it. Always talk to your OBGYN. An example of, just to emphasize how much this stuff changes day by day, ondansetron, which is Zofran, was commonly used throughout pregnancy. Today, as of May 2023, the data on this medication is actually controversial, and for that reason, it has been removed as a recommended medication in pregnancy. So just again, anytime a patient becomes pregnant, they should be reviewing their medication list with their OB to ensure that they're getting the best possible care. Let's go through a few generic concepts in terms of medication administration. First of all, if a patient's planning to become pregnant, they should be recommended to take iron and folic acid. Iron, remember, the medical term you're probably going to see on tests is going to be ferrous sulfate. And they should start taking this as soon as they're trying to conceive. We don't tell them to wait till they become pregnant. It should be as soon as they're trying to conceive. And if you want to understand how important folic acid is, one medication that we use to induce abortions is called methotrexate. Methotrexate works by blocking folic acid. And by blocking folic acid, it causes abortions. Goes to show you how important folic acid is. And we want to make sure that patients get this as early as possible, especially since it's really needed in those first few weeks of pregnancy, which is sometimes a lot of patients don't even know yet that they're pregnant. Let's go through a few other drugs and what the recommendation is in pregnancy. For nausea, which we know is very common in pregnancy, pyridoxine, which is vitamin B6, along with or independently with doxylamine, are the today are the current first-line treatments for nausea. Doxylamine is an antihistamine, pyridoxine is a vitamin. Taking each one by itself or the two together, it is available in a combination medication, is the first-line treatment. Some prescription options, those will both be over the counter. Some prescription options would be metoclopramide, which is Reglan, or promethazine, are other prescription options that are possible. For heartburn, we know that's another common issue in pregnancy. We don't recommend PPIs or anything like that. We start with an antacid, but we specifically would rather avoid the antacids that have magnesium and that have sodium bicarb in it. Next, constipation, another common issue in pregnancy. First thing always is non-pharmacological interventions. Remember, increase activity, increase fiber, increase fluid. If that doesn't work and we want to move on to pharmacological treatment, we start with bulk-forming laxatives. If you recall, again, this was all covered in GI. That would be something like psyllium, which is a fiber, or they can use Docusate, which is a stool softener. The first line over-the-counter analgesic in pregnancy is acetaminophen that is preferred over NSAIDs like aspirin or ibuprofen, which are not recommended to be taken in pregnancy. Again, this is based on the latest data. Again, that can change. Talk to your OB before making any official recommendations. Magnesium infusions is another medication. We covered magnesium elsewhere. We covered it when we talked about asthma, but please note that magnesium is another medication that is used in the pregnancy world, and it's used to stop preterm labor. So if a patient begins to have contractions and it's too early to deliver the baby, then we can give them magnesium because it relaxes the uterus. The uterus is a muscle, and magnesium is a smooth muscle relaxant. It relaxes the muscle and it reduces uterine contractions. Patients with preterm labor may also be treated with steroids, especially if we don't think that we can delay the pregnancy endlessly or the delivery endlessly, and we want to boost the fetus's lungs and surfactant. We want to get the lungs ready for delivery into the world, so we could go ahead and give them a steroid. Finally, some patients may have preeclampsia. Again, that's a whole separate topic, but for the pharmacology aspect of it, preeclampsia is primarily associated for what we're going to talk about with hypertension, and that can be treated in pregnancy with methyldopa, hydralazine, or beta antagonists, also known as beta blockers. Next drug class we're going to talk about ovulation stimulants, and the drug that we're going to talk about here is clomiphene. Clomiphene, also known as Clomid, is one of the primary medications used today for infertility. Infertility, by the way, is when a patient has been trying for 12 consecutive months to conceive and has been unsuccessful. What do we use this for? We use it to help patients become pregnant. It does have an onset of 5 to 10 days. It is not recommended to be used for more than a year. There is some detailed instructions here on how exactly it should be taken. I wouldn't expect you to be tested on that, certainly not at the RN level, possibly not even at the NP level, but I did just throw it in there just so you know. One thing I want to be clear on, this drug does not induce ovulation. It prepares the ovary for ovulation. So it grows the ovarian follicle. It does not induce ovulation. What does induce ovulation? That would be HCG. It is a medication that we give. It's by injection, and we could give that to induce ovulation. An interesting fact to note here, and again, this is a pretty obscure fact. I don't know if you'd be tested on it, but HCG can also be given to men to help with infertility. Letrozole is another drug that is used off-label for the same thing that Clomid's used for. Some of the newer studies are now showing that it's actually more effective than clomiphene. Again, depends on what the latest data says at the time that this is being put into practice. But letrozole and Clomid are two options to help a patient prepare for ovulation. The next drug we're going to talk about is oxytocin. Brand name is Pitocin. The mechanism of action is that it stimulates uterine contractions. So it does the opposite of what magnesium did, which stopped uterine contractions. This stimulates it. How does it do that? By increasing the effects of calcium. Again, the uterus is a muscle. You remember from biochemistry and 100 other places so far in your education that calcium is heavily responsible for muscle contractions, and this stimulates uterine contractions by increasing the effects of calcium. What do we use this for? We use this to induce labor, and we use it after labor to control bleeding. How does that work? Well, it induces labor because when the baby's in there and the uterine starts to contract and squeeze, that's going to push the baby out, delivering the baby, inducing labor. On the flip side, after the baby's out and the uterus is now bleeding, if we push down on the uterus, it actually sort of starts to push down on itself, and that sort of direct pressure to help with the bleeding in postpartum hemorrhage. This medication does begin to work within about a minute, and you should educate your patient that this could make you start to feel really powerful, painful contractions, to give the patient a heads up on that, especially as you titrate that medication up, which is commonly done when we induce labor with this medication. You should warn the patient about that. Finally, it does have a very ironic black box warning that it should not be used for the elective induction of labor. That is actually exactly what it's used for off-label, but it does have that black box warning. Next, we have a drug class called estrogen replacement, and the medication here is conjugated estrogen. What does this do? This has the same effects as estrogen that a patient naturally has, that they lose post-menopause, not lose, but decrease post-menopause. What do we use this for? We use this for patients that have symptoms of menopause, such as hot flashes, vaginal dryness. It's also used to treat breast cancer. Keep in mind, generally, the guidelines say we only use this for moderate to severe symptoms of menopause. It's controversial whether we use it or not for mild symptoms of menopause. It does have a black box warning that it increases your risk of endometrial and breast cancer. Yes, I know I said it treats breast cancer. It also has a black box warning that increases your risk of getting it. Plus, it has an increased risk and a black box warning for cardiovascular disease and dementia. Moving on from women's health to men's health, the first drug class we have are androgens, and the drug we're going to talk about is testosterone. Mechanism of action here is that it produces anabolic and androgenic effects. What is it used for? It's used for two things: delayed puberty and hypogonadism. It does have a black box warning that it can cause hypertension and that it can cause virilization in women and children. That means that if women and children are exposed to it, if it's a child, they can start to go through or develop secondary sex characteristics. In terms of if a woman's exposed to it, you can have things like the deepening of the voice, developing hair on the chest, male pattern baldness, et cetera, et cetera. This is not available in oral form. This is parenterally only, similar to HCG that we talked about. That's also parenterally only. Adverse effects of this medication: it can cause insomnia, it can cause aggressive behavior, and a whole bunch of other effects that it can have. This is a controlled substance because this is very well known that it can be abused. So for that reason, it is a controlled substance. The next drug class we're going to talk about, still under men's health, are the alpha-1 adrenergic antagonists. These are used to treat BPH, benign prostatic hyperplasia, and some of these are also used for hypertension. How does it work? Well, right now we're just talking about BPH. It inhibits alpha-1 receptor, which causes a relaxation of the muscles in the bladder neck. By doing that, it helps a patient able to either begin or sustain a flow of urine. These drugs are the first-line treatment for BPH, and we're going to talk in a minute about what other options there are for BPH. Keep in mind, some of these medications, very interestingly in this class, some of these drugs work for BPH, some of these drugs work for hypertension, and some work for both. At the RN level, I doubt you'd be expected to know which is which. At the NP level, you probably should know, but just so you realize, some of these medications work for BPH, some for hypertension, and some for both. Tamsulosin is for BPH, doxazosin works for both, prazosin works for hypertension. Adverse effects of all of these drugs, because they are all alpha-1 blockers, meaning that they cause vasodilation, that can drop your blood pressure. So it can cause orthostatic hypotension, which almost always goes along with reflex tachycardia. All the alpha blockers, just like the beta blockers, very infamously are highly likely to cause sexual dysfunction, also known as erectile dysfunction in men. But this is still the first-line treatment. If a patient does experience sexual dysfunction related to this medication, we would almost always treat that by giving them sildenafil, tadalafil, or vardenafil, also known as Viagra, Cialis, Levitra. The next drug class we have, still for BPH, is 5-alpha reductase inhibitors, and the drug here is finasteride. How does it work? Exactly like the name sounds. It inhibits 5-alpha reductase. This helps treat BPH. Note that this medication is not only used for BPH, it is also used for male pattern baldness, and you'll see a lot of patients taking it for that as well. This does have the same adverse effect of causing sexual dysfunction. Again, in most cases, we would treat that by giving them a prescription for sildenafil. Speaking of, the next drug class we're going to talk about are the PDE5 inhibitors, phosphodiesterase 5 inhibitors. Very famous drug class: sildenafil, tadalafil, and vardenafil, which is Viagra, Cialis, Levitra. These medications work by causing smooth muscle relaxation, allowing increased blood flow to the corpus cavernosum. In other words, in order for a male to obtain an erection, they need to have increased blood flow to that area. And for that blood to stay in that area, this medication helps the blood flow to that area. What is it used for? It's used for erectile dysfunction. It is actually also used, much lesser known, for pulmonary artery hypertension. Also, tadalafil specifically and only, tadalafil is used not only for ED, but it's also used for BPH. Adverse effects. You'll notice that some of these adverse effects, especially headache and hypotension, are very similar to nitroglycerin or other vasodilators. And that's actually because this drug is very similar to nitroglycerin, because nitro, if you remember from our angina lecture, does vasodilate, which is why it causes a headache. Same thing here. It increases blood flow to the penis, which is by vasodilating. So it does have that effect, which if it affects the blood vessels in the cerebrum, that's where we get the headache from. Because it vasodilates, that's where we get the hypotension from. Because it vasodilates, the blood flows to the penis. That's why we have priapism, which for those of you who don't know, is a sustained erection. It can also cause hearing and vision issues. This medication, because it's so similar to nitroglycerin, is an absolute contraindication for being taken with nitroglycerin. In the hospital is a different story. We may still do that, but otherwise it is a contraindication that a patient who is taking nitro cannot also be taking any of these three medications. Please note that all of these drugs for ED are often prescribed along with many other medications. We talked about two of them earlier in this lecture, the alpha blockers and the 5-alpha reductase inhibitors, but there's a whole bunch that we've already covered throughout this playlist. We talked about SSRIs, TCAs, MAOIs, all of those cause ED. Alcohol causes ED, benzos, and so many more. Very often, if the patient needs to be on that medication, we'll still give them that medication. We'll just also give them a prescription for sildenafil or another one of these in order to address the side effect if a patient's experiencing it. Finally, really quick, just down and dirty, STIs. When we're talking about these, we've already addressed all of these medications, but depending what school you're in, what curriculum they're using, they may cover STIs here in the reproductive health section, so I didn't want to leave it out. So really quick, chlamydia is an STI. It's treated with doxycycline or azithromycin. Gonorrhea is an STI that is treated with ceftriaxone. Very importantly, most guidelines say that if you're treating for one of these, we treat for both of these in terms of chlamydia and gonorrhea because of how prevalent they are, that they go together. Syphilis is treated with penicillin G. Again, we talked about that in the infectious disease lecture. A herpes outbreak, remember herpes you have for life, there's no cure for it, but we can manage the outbreaks, and that would be with acyclovir or valcyclovir or famciclovir, any one of those antivirals. Trichomoniasis is treated with metronidazole. Remember, metronidazole is the one medication that we have that can address that type of pathogen. We don't have any others that can do that. Also, remember, metronidazole very famously cannot be taken with alcohol because of known severe interactions that can cause a antabuse-like reaction. Candidiasis, that's a fungal infection that is treated with fluconazole, which is diflucan. Here are your references for this lecture. Thank you so much for watching. Have a great day.